So I am Lisa Lazarus, and along with my social science track co-chair, Rob Lorway, we have the tremendous honor of welcoming the social science plenary, Dr. Notisha Massaquoi, who's currently an assistant professor in the Department of Health and Society at the University of Toronto-Scarborough, with cross appointments in the Factor Inwintosh Faculty of Social Work and the Temerty Faculty of Medicine. She is also the founder and director of the Black Health Equity Lab, which conducts community-based health research and works with Black communities to develop advocacy tools, strategies, and programs to improve health outcomes, well-being, and success in Canadian systems. During her early health leadership career, she helped establish several organizations which serve Black communities in Canada, including Africans in Partnership Against AIDS and Taiabu Community Health Centre. Most notably, she served for over 2 decades as the executive director of Women's Health and Women's Hands Community Health Centre in Toronto, the only community health center in North America specializing in primary health care for Black and racialized women. So please help me in welcoming Dr. Massaquoi.
Thank you so much for that welcome. Good morning, everyone. Okay, that was the interactive portion of my talk today. Let's try again. Good morning, everyone.
Good morning.
Thank you. It is truly an honor to join you today and to participate in this very important gathering of researchers, community leaders, practitioners, and advocates who are working to advance knowledge and action in HIV research. I want to begin by acknowledging Treaty 1 territory and the home of the traditional lands of the Anishinaabe, the Innu, and the Dakota people, and the national homeland of the Red River Métis. I want to emphasize that this work to advance Black communities cannot be done at the expense of our Indigenous brothers and sisters or their communities. I understand that the HIV disparities experienced by Indigenous and Black communities are deeply intertwined through colonization. I work in solidarity, and I respect the terms of reconciliation and honor the treaties in the land that I have the privilege to do this work on. I also want to acknowledge the important role that the social sciences play in the HIV response. Social science research has consistently reminded us that HIV is never simply a biomedical issue. It is deeply shaped by social structures, histories of exclusion and marginalization, systems of power, and lived realities of our communities. Today, I want to talk about what it means to move from dialogue to action in addressing HIV inequities affecting Black communities in Canada. More specifically, I want to explore how we can rethink HIV research in ways that center Black knowledge, respects Black community leadership, and moves us beyond documenting disparities and towards achieving health equity. Professor James Ward yesterday in his plenary discussion eloquently highlighted the need for us to place equity at the center of all of our work. I also want to give a shout out and acknowledge the students of the Black Health Equity Lab, whose commitment to advancing research with, for, and by Black communities is the foundation of my discussion today. I do not walk alone in this presentation. I have to do a good job because I'm accountable to these 18 Black students who I believe are the future of Black health research in this country. In 2005, along with Wangari Thoreau and Sinait Tekplum, we published our first research study which looked at the experiences of Black women living with HIV in Canada. What we didn't know at that time was that it was not only our first study, but it was the first study in Canada which looked at HIV in Black women. I actually didn't come to understand that fact until Dr. Mona Lutfi's Mark Weinberg lecture a few years ago, where she mapped the histories of Black women, or the histories of women and HIV research. But in this participatory study, our community provided us with 9 recommendations to address the challenges Black women were experiencing as they navigated living with HIV in Canada. 20 years ago, Black women told us that in order to change the trajectory of the HIV pandemic for them, we needed to do the following: increase HIV education and prevention for Black women, increase accessibility to HIV/AIDS services and programs for Black women, support the development of skills and cultural competency for service providers working with Black women, increase funding for service expansion for Black women and their communities, increase HIV research funding for Black communities, link the global epidemics in Africa and the Caribbean to the local epidemic in Ontario and Canada, increase funding for Black community development to address the social determinants of health, provide HIV prevention education, treatment, support, and care services on a continuum, and develop programs aimed at reducing HIV/AIDS-related stigma and discrimination. Unfortunately, 20 years ago, we did not have the political power to implement these recommendations. We did not have the financial resources, and most importantly, we did not have the widespread support of the HIV research and advocacy community, and allyship with Black communities was not yet a concept. The result is truly a lesson in what happens when you do not listen and you do not work collaboratively with the communities most impacted by HIV. What we see is that when we look at the data 10 years post that first study, we see the exponential increase of new HIV cases for Black women in every health region of the province. Our study took place in Toronto Central, down at the bottom, and 10 years post that study, 70% of all new HIV cases were attributed to Black women. And that pattern showed up all across the province. It didn't matter where Black women lived in the province of Ontario. After 10 years, we made up the bulk of all new HIV cases in our province. In fact, over the course of the HIV pandemic, the rates of HIV for Black communities has never stabilized. It has never decreased. It continues to increase up to today. We still lack a comprehensive national picture of Black health because race-based data is not consistently collected across Canada's health systems. And even as disparities are widely acknowledged, the knowledge infrastructure required to address them remains incomplete. Much of our HIV research and literature has focused on documenting disparities. These studies have been critical in bringing attention to inequities, but they have also revealed a very troubling pattern that we all still participate in: the normalization of Black suffering. We know a great deal about the problem. We know very little about effective solutions for Black communities. And at the same time, the number of funded Black researchers leading HIV research focused on Black communities remains relatively small, as you can tell by our presence here, or lack of presence here at CAHR. Community voices are often consulted, but they are not always meaningfully integrated into the design and leadership of research initiatives. And the metrics we use to measure health outcomes often fail to capture the cultural realities, the histories, and the lived experiences of Black communities. What this suggests is that the challenge before us is not only about generating new research. It is about transforming the way research is conducted in Canada. We need a paradigm shift for all of us in this room today. I don't think anyone wakes up every day deciding to do the worst research possible. But we have to admit that our best efforts have resulted in HIV disparities for both Black and Indigenous communities in our country. We need a paradigm shift that moves us beyond describing disparities and towards building the infrastructure for equity-centered HIV research and action. What I learned from that first study was to not start from the place of disparity when working with Black communities. In that study, we started from the place of understanding the lived realities of Black women and respecting that Black women were experts in their own lives and Black women had solutions to address what they needed to make those lives whole and healthy. We made sense of the fact that Black women were able to orient themselves and to stand up straight in one of the most disorienting situations anyone could experience. In response to these challenges, my work is focused on developing community-led approaches to Black health equity research. And I'm going to be sharing one example of this approach, which is the development of an Afrocentric dialogue model, which is grounded in principles of participatory action research and community engagement. This model recognizes that knowledge does not reside only within universities and research institutions. It also exists within communities, in lived experience, in cultural knowledge, and collective histories. The CONA project is my way of decolonizing my own research practice. I don't throw stones, I look at myself first. That work could be understood, and the work needs to be understood by my ancestors. My work as a researcher needs to be understood and made sense of by my ancestors. And I choose the language of my grandmother, Mende. I'm originally from Sierra Leone. CONA means to give a report, to give an account for, to give an account of, and to answer to your community. The goal of the CONA project is to create Black community-informed research agendas that moves towards population-level health system solutions and away from descriptive studies of Black health disparities. In this model, we do not conduct research for the sake of conducting research or for academic output. The goal is to conduct research in a manner that prioritizes the transformation of the undesirable situation that Black communities find themselves in. That our motivator and directive is to transform the undesirable situation that Black communities find themselves navigating. What is most important is to be clear and that the community understands what my intent is as a researcher versus the goals and objectives of my research study. I wake up every day understanding that my research intent is to guarantee the survival and well-being of Black people. The CONA dialogue model was a process that involved 13 researchers, 6 Black-led community organizations, 4 research labs and institutions, and 4 academic departments. Through a series of facilitated dialogues and very lengthy dialogues, day-long dialogues, over the course of a year and a half, we weren't conducting research. We were in dialogue deeply with each other. We brought together Black health service users, healthcare leaders, community advocates, researchers, and students to participate in a collaborative agenda-setting process. Meetings took place in Black businesses, Black organizations within Black communities. We ate Black food. It was wonderful. Always give people lots of food if you want them to do an enormous amount of work. We used the University of Scarborough's community engagement roadmap, which outlines 8 very crucial steps that one must take when learning to engage as researchers with community members. And we adapted that to form an Afrocentric version of that experience. These very difficult conversations created space for mutual learning. It was difficult to hear as researchers how our institutions had failed Black communities, the lack of respect experienced by Black communities, the lack of commitment on the behalf of researchers engaging with Black communities. But this was a process of accountability. We also had to learn how to introduce ourselves as researchers by not leading with my title, my research, my institution, but simply introducing ourselves to our community by who we are and what our intent was. We moved at the speed of community trust, the speed of Black community trust, which is very slow. And I coined that term from Dr. Omashire Dryden from Dalhousie University. Researchers gained a deeper understanding of the social context shaping Black community health experiences, and community members in turn were able to contribute their insights and expertise directly into the research process. The result was not simply a discussion or a series of discussions over a year and a half. It was the development of a shared research agenda, one that reflects the priorities, concerns, and aspirations of the Black community themselves. It was the creation of a vibrant research community with the goal of serving the Black community through research. Researchers had the opportunity to pitch research ideas long before proposals were shared and grant applications were being prepared. Community got to share details about who they were, what they did, what their challenges were, long before they received those letters of support requests that often are only sent because you serve Black people, rather than deeply understanding what you do and what you need. This process also helped us identify best practices for building stronger partnerships between academic researchers and community organizations. But more importantly, it demonstrated that when communities are positioned as leaders and co-creators of knowledge, rather than simply subjects of research, the nature of research itself changes. After almost 2 years, we agreed on many things as a community, but what I will share with you today are the 10 non-negotiable values that must be in place before you begin your research with Black communities. I'm also sharing this because if you want to partner with me, I'm going to say, did you refer to the 10 values first? One of our participants noted, what we are building here is not just a research framework, it is a blueprint for Black liberation. Value number 1, accountability to community. Research must begin and end with Black community. Accountability means a continuous relationship, not a one-time consultation. I know I am doing well and serving the Black community well when that community tells me I am doing well. Within my research, I have to involve the community and give them opportunities for feedback throughout the entire process, not the evaluation at the end. I need to understand how I'm doing and how my research is impacting that community throughout the entire process. We have to ensure as researchers that we are giving more to the community than we are taking. Value number 2, transparency and reciprocity. Data must circulate back to the people who made it possible. Knowledge sharing is an act of caring. It is telling us that you care about our survival and well-being as Black people. Number 3, collective power. No single researcher, no single research institution, no single organization can carry this work alone. The magnitude of the work to address the HIV disparities experienced by the Black community has to be collective work. This is not the work where you're going to gain your solo notoriety. We have to create a collective commitment to the health of all Black people through all of our research in this room. Value number 4, liberation through evidence. Data can be a tool of oppression, but data can also be a tool of liberation. The choice lies in how you choose to use your research, how you choose to protect Black people in your research. It is the ethics of representation. How we are represented as Black people through your research will be how we will be treated. Hope as methodology is the 5th value. This is the refusal to let disparity define Black health outcomes and to let disparity define who we are as Black people. Value number 6, research as relationship. Meaningful community research must start with relationship building, start with mutual respect and trust. It should not start with data collection. My favorite example of research as relationship is the relationship that we were able to build when I was the executive director at Women's Health Community Health Center with the Positive Pregnancy Program at Unity Health in Toronto. This is a program led by Dr. Mark Uden and Jay McGilvery, who's a midwife and an obstetrician duo, to deliver effectively. We almost had 100% actually success rate in terms of delivering babies for positive birthing parents. It's been an incredible partnership, one that I'm very emotional about because of the success of this program. And it involved years and years of building relation, building trust, understanding that when we made those referrals of Black birthing parents to that program, that they cared about those women in our community as much as we did. That relationship evolved long before any research took place, so that when it was time to do research, the community understood that this team always gave more than they took. And that is how the research would also play out when we worked with them as a team. The seventh value is understanding that the community is the expert, community as expert. We believe that the expertise needed to improve Black health already exists within the community. Researchers and institutions must learn to listen, must learn to support, and learn to follow. We are no longer using the language of building Black capacity, which often shows up in our research proposals. We are not building the capacity of Black people. We are ensuring that we treat them as experts in the research process. I will talk about the Aya Circle of Care expert committee that you saw the picture of shortly. Value number 8 that must be present, the decolonizing knowledge production, the decolonizing of knowledge production. We challenge the colonial hierarchies of academia in this model. We envision a future where Black community ways of knowing are central to research, design, and dissemination. Number 9 is intersectionality and inclusion. The language of intersectionality is tossed around quite a bit without the acknowledgement that it was a term that was developed by Kimberly Crenshaw, a Black legal scholar in the United States. When we deeply understand intersectionality for Black communities, it's understanding the Black diasporic experience that we're having in Canada. Canada has a distinction of having the most diverse Black population of people in the world outside of the African continent. Our research needs to reflect that level of diversity and specificity for our experience with HIV in Canada. And the final value that must be shared between researchers and working with Black communities is a shared vision for Black health equity. It's the understanding that there will be Black people in the future, that you will guarantee that we will be in the future. Our emerging research agenda, it reflects an insistence on justice, on joy, and longevity for all Black people in Canada. It centers healing over harm and collaboration over competition. A colonial system pits us against each other. It forces us to engage in competition, and we refuse to take that position. We will always prioritize collaboration, and we will not engage in competition in this HIV world. So, that's a lot of theory. What is the practical application of all of those values? How do we work differently? How do we produce different outcomes for Black people in our work together? And we want to think about how do we move towards equity. So I'm going to go back to that first study and those 9 recommendations that Black women gave us, the blueprint for how to do this work better. And I'm going to take one of the recommendations and walk us through what it would look like if we applied the values that I just talked about. How do we increase accessibility to HIV/AIDS services and programs for Black people? When I take a look at that study, one of the first things we wanted to do is to actually understand the realities of Black women. And when we think about accessing HIV services, we mapped out where are HIV services located in the community that this study took place. That red circle indicates where in the Greater Toronto Area, 93% of all HIV services are located. Unfortunately, those services are located nowhere near where Black people predominantly live in the city. And you could see where Black people are traveling from to get to that red circle. And if we take a look at the large blue area to my left, it's the neighborhood and community of Scarborough. Scarborough has the distinction of having one of the largest Black populations, but one of the highest rates of HIV in the country. 10% of the Black population, or 10% of the population identifies as Black, and they make up almost 30% of the HIV cases for that region. Now, this alone is not enough for us to move forward with funding for a research proposal or is a research ideal in and of itself. And so we wanted to take a look at what research currently exists that might be able to tell us something more about Black people and accessing HIV services in Canada. Very little research exists. I could find very little. And then a wonderful thing happened. This is value number 2, reciprocity and transparency. I received a call from Dr. Mona Lutfi, and Dr. Mona Lutfi conducted a study, what we call the CHIWO study, the Canadian HIV Women's Sexual and Reproductive Health Cohort Study. I received a call, and she said that she had a large cohort of Black women in that data set. And she was looking at women and HIV across 3 provinces. And full transparency, that data had not particularly been analyzed in relationship to Black people and Black women. And as a new researcher, she offered to transfer that data to my lab. She not only transferred that data to my lab for us to take a look at, but she transferred funding that was remaining from that study to enable us to develop a governance process following the EGAP principles to govern that data, as well as to conduct the data analysis on that data. So what I was able to find from that data is that Black women were traveling the farthest when we look across the country to access HIV services. They were spending the most money to access HIV services, and they were spending the most time to get to the HIV services. 25% of the Black women in that sample were spending up to 3 hours one way to get to HIV services. This in of itself was not enough for us to move forward with research because we needed the community expertise. And I had the privilege of putting together an incredible community advisory committee of experts in Black communities living with HIV. Chantel, Salam, Asha, and David, I am forever grateful for the commitment and the level of leadership and direction you were able to provide us throughout our entire work on this particular project that I'm about to talk about. Salam and Asha are here presenting their own research, which is also a wonderful way to see that community can move into research themselves. Through engaging with these experts, we were able to come up with a beautiful research question that seems quite simple, but was very, very powerful. What would happen if Black community members could receive HIV services and care within 72 hours of receiving diagnosis? And what if they could receive that care close to home? And what was the most pressing health issue or health service that Black people needed to access? Primary health care. And so we decided to develop an HIV primary health care program for Black people in the Scarborough region. We approached the Ontario HIV Treatment Network because you need funding for something that big. And in the decolonizing, which is one of the values that we wanted to exhibit, instead of just submitting the traditional proposal, I set up a meeting with the OHTN. I told them what my end goal was going to be before I submitted the proposal, that we wanted to develop an HIV primary health program for Black people, and at the end of that pilot that we would carry out, we wanted core permanent funding so that we could leave the community with the program. I also told them that we move at the speed of trust of Black communities. So I need an extension before I even submit the proposal. Your timelines are not going to work. And that we'd just come out of COVID, and to ask a community organization to take on a full HIV program for the first time would be too taxing. It would be too much. We'd be taking more than we were giving. And so I also needed the funding for the clinical staff that would be providing the services, which was a big ask because the Ministry of Health had not funded any primary health care services for many years at that point in time. So I needed them to advocate to get the funding for the service providers who would be providing the service. And I also needed them to negotiate with my university so that the funds that they were giving the university could be transferred to the community seamlessly. I then reached out to researchers because I needed a team before submitting this proposal. I needed epidemiologists, I needed implementation scientists. Dr. Lawrence Mbuagbo is here. He agreed to participate as one of the researchers, but when I met with those researchers, I told them, my priority is not going to be your academic output, and in fact, you're going to do a lot of work for a number of years, and I don't know when you're going to get those outputs. I will not pursue academic outputs until we guarantee this community that they have an HIV clinic. Dr. Lawrence has a poker face, so I, up to today, don't know what he was thinking or what he thinks about me, but he agreed. He went along with it, and we submitted the proposal. We went back to the community while that proposal was in process, and with the advisory committee, we consulted experts who we felt could tell us exactly what that primary health care program needed to look like, specifically serving Black people in Scarborough. And here are some of the things that they told us. The program should be geographically focused and located in communities where Black people live. Up until this point, even though we had the highest rates of HIV in the GTA, there were no HIV services in communities where we lived. Services should build on the racial and cultural strengths of service users, and services should be led by Black providers grounded in Afrocentric principles and trauma-informed care. We knew how to provide primary health care services, but not specifically customized to Black community members. The program should provide services for family units. We had gender-specific services for men. We had gender-specific services, which I led at Women's Health and Women's Hands Community Health Center for non-binary and trans folks as well. But we did not have services that were designed specifically for Black family units. And the program should centralize the social determinants of health and provide solutions for health disparities experienced by Black populations, understanding the impact that anti-Black racism specifically has on Black communities and what the social determinants of health look like specifically for Black people, and then understanding that our programs have to centralize those experiences. We decided that we needed an organization that could house all of this information, take it up, and be able to create a program that was going to be effective for Black people, specifically in Scarborough. And Taibu Community Health Center was chosen as that organization, not only because that they provide primary health care already for Black people, but because they were trusted and respected by the Black community. Taibu is not just a provider or community, but a family that makes you feel like you belong somewhere. This is a quote from one of the clients of Taibu. Taibu agreed to take on this program. They agreed to customize this program. And because we had engaged in a very long relationship building process that I talked about earlier, we already trusted each other. What developed was the Aya Circle of Care. The staff who were hired were an incredible group of family physicians, nurse practitioners, nurses, social workers, and peer navigators. And what they developed was the first HIV primary health care program for Black families in Canada. that program very quickly, within a year, scaled up to full capacity with a 100% retention rate in care of all clients and a 97% viral load suppression rate. I knew that the pilot was working when the first Black birthing parent arrived in the program, newly arrived in Canada, 8 months pregnant, through the immigration process, received an HIV positive diagnosis, had never had prenatal care up until that point, or HIV support and care. And when that person arrived at this clinic, we were able to leverage that long-standing relationship with that positive pregnancy program. And we knew when we referred that client to Dr. Uden and Jay McGilvery that they would guarantee the survival and well-being of another Black community member. And our first baby born in the program was born HIV negative. And her mom named her Aya after our program. Our story doesn't end here. I've talked to you about how we took those values and created something pretty spectacular as a community, collectively, together. Our story ends with understanding that we have a shared vision for the future of Black community health, the future of Black people and HIV. Beth Guillerme was the coordinator of this project, and she completed her master's degree throughout the delivery of this program as the research coordinator. And I'm very happy to say that Beth has been accepted through the support of this program into the Doctor of Public Health program at the University of Toronto, starting in September. And she is also the recipient of the Dr. Winston Husbands Leadership Award from the OHTN, which is $150,000 to continue the HIV research that we've started together. So ultimately, the goal of this work is to move beyond a research paradigm focused primarily on documenting disparities. Instead, we must focus on advancing equity-focused research that develops and evaluates interventions capable of changing outcomes for Black people. That has to be our focus, to change the current outcomes for Black people. This means addressing the structural factors that shape vulnerability to HIV, including anti-Black racism. Equity is not simply about reducing disparities. It is about ensuring that all communities have the same opportunity and the same access to resources to achieve the highest possible level of health. The call to action to all of you here in the room, the call to action is to understand that achieving HIV equity will require rethinking the relationships between researchers and communities. Community engagement must move beyond consultation towards genuine partnership and shared leadership, and strengthening the pipeline of Black scholars and researchers working in HIV has to be a priority. Representation matters, not only who participates in the research, but also who defines research priorities for this country. We also have to align research, policy, and community action in ways that translate knowledge into real-world change. So what does this mean for all of you here today? The title of my talk is From Dialogue to Action. Dialogue is essential. It creates the conditions for understanding. It creates our conditions for collaboration. It creates the conditions of trust, but it is not sufficient in and of itself. Our next phase of HIV research in Canada must focus on transforming this dialogue into policies, into programs, and research initiatives that fundamentally change the trajectory of HIV outcomes for Black communities. If we succeed, we all succeed. The result will not only be improved HIV outcomes, but it will also demonstrate the transformative potential of Black-led research and Black community-led research to advance health equity more broadly. I'm going to close with this thought. Black communities in Canada have long been subjects of HIV. I'm not disputing that. What we are calling for now is something different. We are calling for a future in which Black communities are not only participants in research, but respected leaders in shaping the knowledge that informs policy, practice, and public health action. We are calling for a future where HIV research reflects the realities of the Black communities it seeks to serve. And we are calling for a future where equity is not simply an aspiration. This is not about Notisha's dream today. We are calling for a future where equity is not an aspiration, but it is a non-negotiable outcome of our collective work that we conduct together. Thank you.
Thank you, Dr. Massaquoi. You've given us so much to think about. And I think it's the kind of thing we need more time to ruminate on. Unfortunately, we don't have a lot of time. But I think we can squeeze in one question. And if we can open it to the floor. Okay. Okay. Are there, yeah,
I'm shocked to see there's no questions.
there's a lot to think about. Yeah.
I'll give you a question, Notisha. How, as allies, if you consider us, when you consider us allies, and I know how well you collaborate, my tears certainly welled up when we talked about Mark and Jay McGilvery. What is your message to us?
I think the key thing to understand is that I think we have a history of relying on the Black community to stand up and take care of itself, because we will. But we rely on that perseverance of survival without providing adequate resources, support, without leveraging the privilege that others in the room have to help us do that work. And I think allyship for me is really about leveraging your power and privilege to allow us to lead, but understand what supports you can provide within that allyship. Allyship also means that when we are very small in number and we're not in particular rooms or spaces, especially those where decisions are being made, that you can represent us in those spaces, that you can advocate for us in those spaces, and not necessarily take advantage of our absence to push agendas forward without us. And to understand that there is no HIV agenda that we can move forward that does not include Indigenous and Black people.
Let's take one last question. We'll squeeze it in.
Yeah, thank you, Notisha. My name is Ngozi Joy Kichebel, University of Northern BC. I'm a postdoc fellow with CTN, supervised by Nathan Lachowski. I just want to say thank you for this presentation. It was breathtaking, it was overwhelming, and to know what is ahead, even for Black health research. Thank you again for bringing it out. That is just what I want to say. Thank you, Notisha.
Thank you.
Okay, and we'll close there. And thank you very much on behalf of the organizing committee. We just have a small gift for you.